Hello, and welcome to HIV.gov's coverage of the 2022 Conference on Retroviruses and Opportunistic Infections, or CROI for short. Today, we'll be focusing on three things. First, an important study on cancer prevention among people with HIV. Second, research on HIV and aging. And third, research on long-acting HIV prevention options and treatment options. I'm Steve Holman, and joining me again today is Dr. Carl Dieffenbach. Carl's the director of the Division of AIDS at NIH's National Institute of Allergy and Infectious Diseases. Welcome, Carl. Thanks for joining us. We've got a lot of interesting topics to discuss today.
We do. We just finished the second week of CROI, and we are going back to one of the topics that was presented last week, and then finishing up with ones that were presented this week. It's been a very full 2 weeks, and the conference really had some really wonderful science to present.
It's been an invigorating couple of weeks. And thanks to our viewers for joining us. Viewers, if you have questions about the research that we discuss, post them in the comments section below the video and we'll try to answer them. Carl, let's get started with important study findings that were presented at CROI about preventing anal cancer among people with HIV. What did the anchor study set out to investigate and how did they do it?
So let's take a step back and remind everybody that both cervical cancer and anal cancer is caused by a virus called human papillomavirus. And for treating cervical cancer, there's a standard procedure where there's a type of lesion that occurs on the cervix called high-grade squamous interepithelial lesions. And I will not say that again, or HISIL for short.
HSIL, right?
HSIL, HISIL, right. Now, it turns out that it's the exact same lesions that occur in the anal canal, but no group has ever been able to complete or do the kind of study that tests the interventions that are used for treating cervical cancer until now. The NCI set off in 2013, 2014 to perform this study, looking at the effectiveness of treating HISIL as a way of reducing cancer in people living with HIV. They also wanted at that same time to figure out about the safety of the treatment, as well as collect samples for biomarkers, and also to figure out ultimately if there was a way to predict what the characteristics of the person's cancer or HISIL lesions or status, immune status, would lead us to create a predictive model of who would progress.
And the idea here is that those lesions are precancerous, right? So if you're able to detect and intervene, you might be able to prevent progression to cancer. Do I understand that correctly?
That's exactly the point, is that these lesions have a high propensity of moving to full squamous epithelial cancer. And as again, following the cervical cancer playbook, by treating those lesions, we significantly reduce the appearance of cervical cancer. Will the same issues hold for anal cancer?
And if I remember correctly, they explained that anal cancer, I think, was is it the fourth leading cause of cancer among people living with HIV? So
it is the number 4 cause of cancer in people living with HIV. And keep in mind that one of the consequences of HIV disease that we saw from the START study, I'll talk about more about that in a little bit, was increased incidence of cancers in general. So HIV infection does create a propensity for cancer. We have this other virus now, the human papillomavirus, that is also then causing these lesions. So there is a relatively high rate of these cancers in people living with HIV.
So how did the researchers in the anchor study that you mentioned, sponsored by your colleagues at the NCI or the National Cancer Institute, another part of the NIH, how did they go about the study to test the intervention?
So first they had to identify an appropriate population to perform the study. So the minimum, usually you think about clinical trials and you think there's a cutoff of an upper age. Here there was a minimum age. They wanted people that were 35 years and older, and they wanted people that had been living with HIV and had then obviously to come in and get screened for these lesions. So in the end, the average age of the people enrolled in the study was over 50, 51. The average time that people had been living with HIV was 17 years. So this was also the level of viral suppression was quite high in the study, and the CD4 count was quite high as well. The study was incredibly well balanced. It was 16% women, and the rest mostly men, and there was also a significant number of transgendered individuals. And then it also was really well balanced demographically. It was essentially evenly split between African Americans, white people, and Latinos. So it was, incredibly well balanced. A small fraction of about 2% Asian Americans. So we had this really good group. They screened 10,000 people and ultimately recruited about half into the study, and then divided it up into people that received either the treatment, which was they were biopsied on suspicion of HISIL. If the HISIL was detected, they were treated and then continued to be monitored. There was a fair amount of recurrence, but they again continued to go back and make sure that all the HISIL lesions were treated. The control arm was active monitoring. They watched people every 6 months, biopsied annually to confirm persistent HISIL, and then continued to look for cancer. And then if cancer was detected, took appropriate steps to treatment. So there was the two arms. It was active monitoring, so they watched to make sure that people were not progressing to cancer. And then for the active intervention was actually aggressively treating the HISIL.
So what the researchers followed these individuals for a couple of years, right? What did they end up finding?
So in the end, this was an event-driven study. So that's important to note. This wasn't time-driven. So they needed a minimum of 31 cancers in order to power the study. They were able to find 32. Upon closer reflection, 2 were eliminated, so they ended up with 30 cancers. Importantly, 21 of the cancers occurred in the active monitoring arm, and only 9 in the treated arm. And so it showed a significant impact of the treatment in terms of preventing progression or eliminating the possibility of progression to anal cancer. So at these kinds of numbers, they were in the control arm, where the numbers of around 400 or more per 100,000 person years. So it's a significant impact, a significant amount of cancer. And I think that's one of the major conclusions of the paper, of this entire process, is that with this much cancer, we really need to it really calls for a change in how we deal with it. We must get to a point where we are using this technology to monitor and treat cancers. We need to be able to make sure that we have the biomarkers, and we need to really be able to optimize and improve the screening regimens for HISIL. So this was a critical study. It's identified a path forward for dealing with anal cancer, and in a way that will make a difference in the lives of people living with HIV. Importantly, this will now need to go and also be looked at from other groups that are immunosuppressed for other reasons, and look and see if the same sort of treatment will work for people with also at risk for cancer. One of the challenges that really needs to be addressed is training. There are not sufficient physicians trained to perform the technologies that were used to treat HISIL. And so there's got to be some additional work done in terms of bringing forward additional physicians that can do this kind and are trained to do this kind of intervention. Because it's not as simple as taking a mole off your skin like a dermatologist would.
Well, important results, and it sounds like you're suggesting this could end up changing the standard of care for people with HIV. Is this, just to kind of connect some dots or see if I'm connecting dots correctly here, is this the type of study that the experts on the various panels that come up with the HIV treatment guidelines, was this the type of study that they would consider when updating guidelines that basically are the standard of, communicate the standard of care in this area?
I think there is a place for, not necessarily in the antiretroviral treatment guidelines, but there should be guidelines for dealing with HIV-associated cancers, and I think that would be where that would end up, because I clearly it will no longer be sufficient to care for somebody living with HIV and not ask the question, how are you feeling down there, as it were, and then perform appropriate examination and either refer or treat. It's not enough just to watch anymore. And I think that will be, I mean, what we want is to make all cancers, preventable to a point where people won't progress. And this is a big step forward for people living with HIV.
That's great news. All right, so that's our first topic, and it seems particularly significant given the high prevalence of anal cancer in the population that you discussed. And I guess one of the things that I'm wondering is, as more people living with HIV live longer because of effective treatment, does that mean that the occurrence of HISL or other comorbidities is also likely to grow?
That was a brilliant segue. Even if, Steve, I think you really captured exactly why we grouped these today. It's because we're dealing with populations here 50 and older, talking about cancer. The other major theme of one of the major themes of the meeting was aging and HIV. And what does it mean to be getting older and living with HIV? And that was, there was a session, the very first session of the meeting was about that. And the next to last session of the meeting was about that. And it's really important to take a step back and think about what we're dealing with here. So prior to antiretroviral therapy, there was no aging with HIV. And so what we have is a situation where what we are studying now is the effect, is aging in people with treated HIV disease. And what has been clear, or we've learned over the years, and starting with the START study and the SMART study, and from the SMART study, we quickly realized that stopping and starting antiretroviral therapy was incredibly deleterious. You want to get on therapy and stay on therapy, because every time you stop and start, you're essentially taking your body through a massive amount of immune activation time and time again. The START study looked at the advantage of starting antiretroviral therapy as early as possible and demonstrated that it's never too soon to start. And the sooner you start, the better, because every passing year of not being on therapy, there's damage being done to your immune system that you're not aware of. And one of the ways there's damage is it shows up as an increased level of cancer. But at the same time, what we have seen is that even with antiretroviral therapy, there is still a level of immune activation that is residual, caused by all kinds of things, residual virus production from the reservoir that's defective, other co-infections like cytomegalovirus, lifestyle choices, smoking, alcohol use, drug use, all contribute to activation of the immune system. And that is driving the appearance of a state of chronic inflammation, which helps promote certain forms of diseases that are advancing as and appearing as aging. And the primary of those are in people living with HIV is cardiovascular disease. That's where we have seen it quite significantly. We know that early antiretroviral therapy does mitigate some of the risk, but there is then accelerated the appearance of aging in people with lung disease, liver disease, and cancer. But in the meantime, we are seeking ways to mitigate that kind of risk in terms of advancing with cardiovascular disease. And NIH is participating or performing a very large study of looking at the effect of statins on heart disease, called the REPRIEVE study. This has been going on for a long time, and there was actually data presented on other statins at this meeting showing that a statin treatment, even a reasonably short course, had an effect on certain biomarkers. So I think that we're in good shape in terms of looking at, through REPRIEVE, the effect of a statin on cardiovascular disease. But that doesn't get away from the fact that still, even if you're not having heart disease, there are other changes that have occurred in your body. You have altered lipid profiles, you have changes in microbial translocation that are helping to continue to drive this level of chronic immune activation. And that then translates into other consequences like frailty.
And these are all many of these areas were discussed in studies that were presented at the conference, and the NIH research portfolio across the many different institutes and centers is touching on many aspects of this. And that's actually a good thing, right? Because as you alluded to earlier, because HIV treatment is now so effective, we have people living with HIV who are living into old age. And it's sort of a new frontier, which is why you and your colleagues are investigating all of these different outcomes of living longer with HIV.
Yes, there's two parts of it. There's the research side, but there's also the care side. And I think that one of the major themes that was brought forward at the meeting was that the care of people living with HIV has not kept up with the reality of this aging population. And there needs to be some consideration for how to deal with somebody who's moving into frailty and moving into this status where they have multiple comorbidities and they're just slowing down and having these consequences of this level of immune activation. So we need to make sure on the research side that we're doing what we can to prevent these diseases and prevent the emergence of frailty. But as frailty does emerge, and at some point we're all going to get old and may get frail, but there's no reason it has to be so accelerated. So how can the health system step up and deal with the needs of these people and integrate a different level of care into the processes of treating people living with HIV. So to that end, HRSA has made an announcement that they have a funding opportunity to look at centers that deal with questions around frailty and function in geriatric HIV clinics. So these are something that we're going to really have to focus on as we think about the national HIV/AIDS strategy. Because as we've talked about last week, the national HIV/AIDS strategy is a whole of government effort to deal with the consequences of living with HIV. And a major part of living with HIV today in 2022 is the aging population. So this is a big step forward for the National HIV/AIDS strategy that HRSA has taken this step. It has to become more than just pilots, but there needs to be, in many ways, a wholesale. The community is advocating for a wholesale change in how HIV treatment is delivered as they age up. People age up. I mean, when you have a situation that people who are 50 and living with HIV between 50 and 55, 10% are frail already, and another 40% are in the pre-frail syndrome, is a very significant difference compared to people who are not living with HIV. So there is it's important that that we as the whole of government address this. And this gets to the leadership we have in the National HIV/AIDS strategy that has been so forward thinking about this, so that dealing with aging in this population is one of the cornerstones of that program.
Well, I know the research that you all are working on is going to inform that, and will engage other folks from across government and in communities to help adapt and move forward the variety of healthcare, social services that older adults will need.
We're all connected.
I'm going to pause for just a second and see if there's any questions from the audience that we should be attending to. I don't see any just yet. Viewers, if you have any questions, post them in the comment section and we're happy to try to answer them. So Carl, let's turn to next, the future of HIV prevention and treatment. At CROI, we've heard several research updates on possible new options for both prevention and treatment. We talked about one of those in our video last week. We don't have time to review all of them because there were lots and lots and lots of presentations in this arena, but can you maybe give our viewers a big picture overview of research in this area? There was even a plenary session on the topic.
So fundamentally, what the goal of people looking at ways of preventing and treating HIV disease is to really help the person who's accessing either treatment or prevention services to make them as successful as possible. So this gets to the questions of adherence and other support services that go along with that. And one way to really foster adherence is to use long-acting or sustained release formulations that can be easily and safely delivered, so that you're in a situation where it's you take a pill once a week or once a month, or have an injection or an implant, and you're good to go until you see your physician again in whether it's 2 months, 3 months, or 6 months. That's particularly true right now on the treatment side. The combination of cabotegravir and rilpivirine can be delivered for treatment for 2 months. And also the single agent, the cabotegravir long-acting, can be delivered at 2-month intervals for the sake of prevention. Both are now approved by the US FDA, and both the treatment and prevention formulations are being quickly reviewed and looked at by regulatory bodies around the world to see if they could be incorporated into their treatment and prevention armamentarium. So this is a big step forward. There's a new generation of molecules coming forward that have different properties. And so it's like with antiretroviral therapy. We started with pills 3 times a day, and then 2 times a day, and then got to a point where we had fixed dose combinations of 1 pill once a day. So the drugs continue to get safer and easier to administer, and also will have an increase in the time between needed dosing. So that is the vision of where we're headed, and it's really important to keep that kind of a sense of it's going to get better and better over time. The other area that's really interesting to think about is dealing with treating or providing medicine to take care of 2 conditions at once. And one area that is being looked at very carefully is providing contraception, oral contraception, that is not necessarily co-formulated, but co-packaged with an oral agent or agents that prevent acquisition of HIV, basically PrEP. PrEP combined with oral contraceptives. And that is an area that is also helping with adherence, because you have multiple reasons to want to take your daily pill in that situation. So we'll see how this all unfolds, but this remains a very active area of study and research, and we're looking forward to seeing how this all emerges. One of the really challenging things we're seeing, or we need to keep in mind, is usually we think of the safety of pills as being the period of time when you're actually taking the medicine. But once you're providing an injection or an implant and the medicine is inside the body, you have to consider the safety of that entire time. And so the studies will take a little longer to do. The safety determinations will take a little bit longer or a lot longer. But ultimately, we will have a suite of choices for people, because that's the ultimate goal. Is we don't want one size fits all. Different people need either prevention or treatment in their lives in different ways, and want to access either pills or injections or implants in different ways. So that's the ultimate goal, is choice.
It's exciting. It sounds like there'll be in the future a variety of options available for people in all sorts of different circumstances, which could really help with achieving either prevention or treatment goals. So we'll look forward to learning more about each of those as more research comes out in this area. Carl, briefly before we close, can you tell us what's on the horizon for HIV research? Any things that we might expect to learn more about later this year?
So I think that one of the areas that there was the announcement of at this meeting is the beginning of clinical trials of HIV vaccines using the messenger RNA technology. And so in some ways, we've seen just how successful messenger RNA vaccines can be in coronavirus vaccination. Now it's time to see if we can figure out how to exploit this really powerful platform for delivery of vaccines to improving and getting us to a point where we can work toward an HIV vaccine. So trials have been, the first dose of at least one of the trials started this week. A different trial started about 2 weeks ago. So this is an area of intense interest. And the other thing to think about is maybe the messenger RNA technology can also be useful in the cure space. And are there molecules that can be delivered via messenger RNA that really help to promote clearance of the reservoir or suppression of the reservoir, or just provide that what is needed to help us advance toward a cure? So I think that coming back to the theme, that the two most important challenges we face on the research side is how do we get to a safe, effective, and durable HIV vaccine? And the second is, can we get to a point where we have sustained virus control, virus remission in the absence of therapy? And maybe the messenger RNA technology will be essential for both.
That's very exciting. Well, I hope we'll have an opportunity to discuss some developments in that area, perhaps later this year. Thank you so much for joining us, Carl. It's been really great to have you discuss these important findings and help us spread the word even further for many of our followers who aren't able to participate in the conference. We always appreciate your considerable expertise in helping clarify some of the things that we hear coming out of the conference.
Thanks, Steve. It's always a pleasure to join you. And this is the third year that CROI has been virtual. They've announced that next year will be, as of right now, is scheduled not to be virtual, but it will be in Seattle in 2023. I would say this year, I feel like the science is really blossoming back to where it was pre-pandemic. We're really seeing the buds on the trees of knowledge growing, and I'm excited about our future.
That's very encouraging. We'll continue to stay in touch about these developments. I'd also like to thank our viewers for joining us. We'll recap this conversation in a blog post, so keep an eye out for that and share it with friends or colleagues who might be interested. And visit HIV.gov for that post and for more information about HIV. That's it for now. Goodbye.